Hi friends, welcome to Charcos. I'm Dr. Seema Balian, the founder and director of Charcos. Charcos is a healthcare recruitment and training company with over 15 years of experience in providing turnkey solution for training and recruitment needs for the nurses, doctors, and AHPs such as radiographers, occupational therapists, ODPs, and many more. OSCE training for all fields of nursing such as adult nursing, mental health nursing, pediatric nurses, midwifery, and learning disabilities. OSCE training is available in India as well as in UK. Orientation for life in UK, OSCE exam bookings and the logistics bookings, excellent pastoral care. Our state-of-the-art learning platform includes reading materials, videos, quiz to enhance your learning and equip you for a positive and a better outcome. For more information, please visit our website www.charcosglobal.com. Our Facebook page, Instagram, and LinkedIn pages by the name of Charcos Global, and subscribe our YouTube channel. Press the bell icon for regular updates and all the information that you require. We are looking forward to seeing you on our site and being a partner in your enhanced journey. Thank you very much.
So as we had discussed, today's topic that what we are going to be discussing is going to be the assessment section of the midwifery OSCE training. Now, before we go on the assessment section, maybe we can just think and take a couple of minutes to just discuss that. What do you guys understand with assessment? So Priscilla and Mercy, one by one, can you just give me a little idea that what is your understanding of assessment? What do you do in the assessment thing?
Please, can I talk?
Yes, of course, go on.
Okay. For me, I know the assessment, it is when your client or your patient comes in. You try to, should I assess it, like take note of one or two things. Yes.
Yeah, Mercy, what do you have to say?
All right. When we talk about assessment, what it entails is that when the woman come in, let me say, if it's the first scene of you, like it's the first day of you seeing the woman, you have to first do your quick observation about the woman, and from there you take back home we say vital signs. That is the blood pressure, temperature, pulse, respiration, to know the baseline data of the woman's condition. And from there, you also do, as a pregnant woman and a midwife turning to a pregnant woman, you also do head to toe assessment of the woman. To that one to give you a baseline data of her condition. So with the head to toe assessment, with the head to toe assessment, you just assess everything on her, and also you do abdominal examination, and also fetal assessment, so that you get to know well of the woman. As back home, I'm picturing myself back home. So after doing the head to toe assessment, you do abdominal examination, fetal assessment, and also what again? And you can refer her to the lab for some laboratory investigation, and also you do urinalysis with when you're doing the vital signs, you add urinalysis. That one too will help you know her protein, her ketones, and other things. That is back home. But with the UK, I don't know UK settings.
No, that's
Yes.
No problems at all. And I think thank you both of you. So basically, when we say assessment, and I don't necessarily mean that assessment as in a midwife assessment, as a what I would say is that assessment is something that before you embark on anything, the observations and the calculations that you make about any situation and the knowledge that you gain about any situation, it becomes the part of that you are assessing that situation. So when we put it in the patient context, then it means that whenever a patient walks into you, assessment is the very first thing that you are going to be doing, because you need to understand that what the situation is. And that's why in the assessment, all of the history taking, observations, finding out the complaints, the problems, all of these things they will become the part of that assessment, so that before you embark on any kind of planning, any kind of medication, treatment, anything, you first need to really understand that what is the issue, what is the problem, what is the current situation, what is the background and history and everything, so that any judgment that you make depends upon all of the assessment that you have done. So it is really important that the assessment is structured, it is detailed, and you are getting as much information as you require to give the best treatment to the patient, or to make sure that the care is best and is evidence-based. Yeah. So this is basically what an assessment is, whether you are doing the assessment as a midwife or as any other nurse or a doctor or any healthcare professional. So that is what an assessment is going to entail. Fine. So today we are going to learn about assessment from the OSCE for the midwifery point of view. So all our patients are going to be from the midwifery point of view. So they are all pregnant or just delivered or in labor ladies. So they will be our patients, and we are going to be doing the assessment of those. Okay. So because it is oriented to the exam as well, so we'll know a little bit about the exam as well, that how the exam is placed and where does the assessment comes. Now, assessment is the first station of the APIE section. Now, we know that in the exam, you are going to get in total 10 stations, 4 of which are going to be the APIE, 4 are going to be skills, and then 1 evidence-based and 1 professional values. Now, when we talk about APIE, basically it is the assessment, planning, implementation, and evaluation. So assessment is going to be your very first thing, because first of all, you need to understand the situation. Only once you have understood the situation, can you plan it? Then only you can give the treatment about it, and then only you can give the handover or discharge the patient. Okay, so it is always going to be in that sequence. API is always going to be the assessment, planning, implementation, and evaluation. The sequence won't change. Have you understood that?
Yes, please.
Okay, great.
Yeah.
So in the midwifery OSCE, there are 3 types of scenarios that you can get. You are going to get any one out of it on the exam day, but there are 3 types of scenarios. It can be either an antenatal scenario, or it could be a labor and a birth scenario, or it can be a postnatal scenario. Yeah, so because you have to be ready for any of this type of scenario to come, that is why we will be learning all 3 scenarios. That what are you supposed to do in all of the scenarios, so that you are prepared for any scenario that can come. So there is a set criteria against you are marked. I have already shared the criterias with you on the on our group, so you can go through those criterias once we have finished with today's session. So in the criterias, although we always say that there are some essential criterias which you have to meet, but my suggestion is going to be that, see, all of those criterias are essential, because they are stepwise criteria. So we can't say that that one is more important than the other. So all of the criterias are essential. But the good thing is that if you look at the criteria, they are the things which you have always been doing. So it is not that any extra thing has been added to it. It is just that those criteria are providing you that how in a structured manner you can do a particular assessment or thing. But sometime if you have done one thing before the other, it is usually, it does not make a difference. So don't panic if you say that, oh, I took the blood pressure first and then I took the pulse. It does not matter. Some things can be interchangeable as long as you are completing the whole of the things. So, but sometimes there are some red flag signs are usually there that if you miss out on anything, then that becomes like that, okay, that was very important. Say, for example, if you don't check for allergies, or if you are not checking the patient ID, and or if you have not checked the patient's the date of birth, because these are some very essential criterias, because you can make mistake. It might be that you take a history of a wrong patient. So these can be lead to failure. So it is important that you make sure that you are checking all of those things as a because that is very, very important. Okay. So then you will be getting 20 minutes to complete this station. You will get an A4 sheet where the history will be given to you, but you will have to cross-check it with the patient. We have already, I've already told you that it is 99% of the time you are going to get a mannequin in the exam, and your examiner is going to act like a patient. But for as far as you are concerned, you are going to be treating even the mannequin like a real patient. So you are going to be behaving as if it is a real patient sitting over there. You are going to be asking all of the questions and everything to the mannequin. The answer, the examiner is going to give the answer, but don't start looking at the examiner because examiner is not the patient. The patient is the mannequin. So you should always be looking at the patient, at the mannequin, and then doing your station. And if there is any other question that you want to ask, the examiner will always give the answer for that one. Okay, so in assessment, apart from obviously taking the complete history, you are also going to do an A to E assessment. So tell me, Mercy, what do you understand by A to E assessment? What does A to E stand for? I've written it down as well, so you can just read it out from there.
Okay. So you are assessing for the airway, the breathing pattern, the circulation, disability, and exposure.
Yeah, so that basically is the A to E assessment. So you are going to be making sure that the patient is breathing all right, or their airway is open. So if the patient is talking to you and if they are otherwise looking quite comfortable, so we would normally say that the airway is clear and they are not having any obstruction. Then you are going to be checking breathing, and in the breathing you will be checking the respiratory rate and oxygen saturations. For circulation, you will be checking the pulse, including the rate, rhythm, volume. You will be checking the blood pressure and the capillary refill. In disabilities, you are going to be checking that whether the patient is conscious and alert. And you, in the exposure, you will be checking for temperature and if they are suffering with any kind of rash or any other problem in the body. So this is basically your A to E assessment that we will be doing. But and all this assessment that you are going to be doing, you are going to be recording it either on a Meows chart if the patient is not in active labor. And if the patient is on active labor, then you are going to be completing all these findings in a partogram. Okay, so we will be seeing both the Meows chart and the partogram very soon. Then, yeah, you want to ask something?
No, please.
Okay. Okay, so, and this we have also discussed that if there is an actor or if there is a mannequin which is there, then all of the readings are going to be provided to you. So it is going to, the examiner will give you all the readings, but you will still need to show to the examiner that how you are going to be taking the readings, that what is the, that how you will take a blood pressure. So we have to be very clear about taking the blood pressure or temperature, pulse, that what is the right way of doing those things. So we should know about that one. Yeah.
Right.
So now,
Okay.
since I have told you that this is the 3 type of scenarios we can get, so we are going to be dealing one by one with each scenario. So first we are going to see that an antenatal scenario. Now, what do you understand by antenatal? So Priscilla, can you tell me that what do you understand by antenatal?
Hello.
Hello? Yes, Priscilla.
Okay, the antenatal, it's the stage before like before birth.
Yeah. So the stage before birth, or
Yeah.
actually before active labor, you are going to be calling them as an antenatal stage. So it can be from the time when you get pregnant till
Yeah.
you go in active labor. All of that time period is called as an antenatal period. And if you get,
Yes.
if you get any patient who falls under that category coming to you for any kind of problems, that is going to be the antenatal patient, and you will be doing an antenatal assessment on them. Okay? So
Okay.
when you are doing an antenatal assessment, as I said, that exactly that is how you are going to. So you say, for example, if you get an antenatal female who is coming and in your exam, and you are given the history of the patient, that okay, this is so and so person with who is say, for example, 34 weeks pregnant, and she is coming with abdominal pain. Yeah. And you are asked to take a history of that patient. Now, Priscilla, tell me that what are the first few steps that you are going to be doing? And don't worry about the criteria or something like that. I really want you to think that in real life, what are you going to do?
Initially, okay, antenatal booklet, the name, history. Then I would do her maternal observation and fetal observation, and I would also do abdominal palpation.
Okay.
Then I also do a urinalysis. Yeah.
Okay.
Then,
So let us.
I'll do a blood sample and all that.
Okay. Let's take one step at a time and then see. See, imagine,
Okay.
and when I say that you need to really think about that what you are going to be doing, please think about like really the basic sort of thing. So if I have been told that there is someone who has a 34-week pregnant lady who has come with a complaint of having abdominal pain, and you are going to go and see the patient. Now, the few things that I'm going to do beforehand, that I will make sure that before I enter the room, I do my hand hygiene. Yeah. I make sure that the scene is safe for me to enter. I'm going to be giving the privacy to the patient. And then I'm going to be introducing myself to the patient, that I'm Priscilla, I'm one of the midwife who is working over here, and I'm here to look after you today. Yeah. And then you are going to be checking that whether you have got the right patient. How do you check whether you have got the right patient? Mercy, can you tell me that what are the things to how you are going to make sure?
Please, we first ask the patient's name. So after patient telling your name, then you confirm with the antenatal book that you are having to see if you are having the right patient. That is what we do back home. Yeah.
Yes.
And
So
also you can confirm with the NHS the OPD number. By here they call it NHS number. That if you have the right patient. Yeah.
Okay. So what we need to understand is that there is a term called as a three-way ID check. Yeah. So when you are doing a patient ID, there is you are going to be checking the patient ID using a three-way ID check. Now, three-way ID check means that you are going to be checking the patient's name, date of birth, and their hospital number by three ways. Yeah. And the first way is that you ask the patient. So it's a verbal sort of thing. So you are going to get a verbal confirmation from the patient. Yeah. So you will ask the patient that, okay, can you please tell me your name and your date of birth? And the patient is going to give a reply. When the patient is replying, the second way is with the documentation that you have got. So when the patient is replied you are going to make sure that the documents also say the same thing. The patient's name and the date of birth is written correctly. You will also ask the patient their hospital number. Yeah, so they might not know the hospital number, but you are going to be checking with the patient ID band. Now, that is the third way of checking with the patient's ID band. On the ID band, there is going to be the patient's name, date of birth, and their hospital number. So the hospital number, name, and date, they should be matching with what the patient has told you, with the documents and with the ID bracelet that they are wearing. Okay, so this is called as a three-way ID check. So if we see that we have made sure that we have entered safely, we have done our hand hygiene, we have introduced ourselves, we have done the three-way ID check of the patient. Now the fifth thing that what we are going to be checking is the patient allergic to anything? Yeah, because you can check, and if the patient is allergic to something, then they are going to have a red ID band as well. Yeah, so you please make sure that if the patient is allergic to anything, and if they are allergic to, then ask what are they allergic to and what happens in the case of any allergy, like whether it is as severe as anaphylactic reaction or whether they just get a rash or something like that. So it's important to check the severity of the allergy as well. And the sixth thing is that you are then going to be telling the purpose of your visit and gain the consent from the patient. So these are called as the introductory six. Have you understood these ones?
Yes, please.
Yeah. So Mercy, can you repeat them? That what are the introductory six? Priscilla, can you hear as well? Priscilla, are you
It's
able to
been
hear?
breaking, but at the moment I'm hearing.
Okay,
Yes.
that's fine. Okay, so Mercy, go on.
All right. If I heard you right, first, if you are approaching a patient, you perform your first you approach the scene, then you make sure your scene is safe for you to approach. Then you
Okay.
perform hand hygiene
Second,
before
yeah.
you approach the patient. So when you get to the patient, you introduce yourself to the patient as being one of the midwives around who is going to take care of her. And
Absolutely.
afterwards, you confirm whether you have the right patient by asking the patient full name and date of birth. So after confirming the full name and the date of birth, you recheck it with the documents you have with you, whether you have the right patient and whether you have the right patient. So after that, then you ask the patient if the patient is having any allergies. So if the patient is having allergies, there will be a red wristband on her hand already. Then that one you can confirm whether the documents you have with you.
Yeah. Okay. Then, so these are 4, which is the 5th one? Did you tell the allergies?
Yeah, then you talk about the allergies, if she's having any allergies. So if she's having allergies, there will be a red band on her hand, and that once you confirm and you reassure her that maybe she will not come in contact with any of her allergies products. Yeah, you give a form of reassurance to her.
Absolutely. And which is the last one? So you are going to tell what is the purpose of your visit, that why you are over here, and you gain a consent from her.
Okay. All right.
Yeah. So you are going to say that, okay, I'm here. I saw from your notes that you have been suffering with some abdominal pain. So I'm here to do an assessment on you. It is going to take me around 20 minutes to do an assessment, and in which I will be asking you the history, a few of the presenting complaints and thing, and I'll also be taking some observations. Yeah. Are you okay for me to go ahead? And the patient will say that yes. Yeah. So you have explained the purpose, that why you are over there, as well as you have taken the consent as well from the patient. Okay. So these are your introductory 6, and you are going to be doing the introductory 6 in all of the scenarios, regardless of what the scenario is. Sometime in certain skills, your examiner might, just to save time and all that, your examiner might tell you that, okay, the introductory 6 has already been done. Assume that you have already done the introductory 6 and then you start. So until and unless the examiner tells you, it is always advisable that you do the introductory 6, so that you have made sure that you are the right person to be doing that assessment. It is the right patient that you are doing the assessment, and you have taken the consent from the patient as well to do what you are doing. Okay, understood?
Yes,
fine,
please.
Great. Now that we have understood, we have explained that why we are over there, then you are going to start taking the history from the patient. And when we are going to be taking the history, the first thing that we do is to take the history of the presenting complaint. Now over here, if the patient is saying that I have got the abdominal pain, you are going to be asking that, okay, tell me more about it. That for how long have you got the pain? How did the pain start? How much is the pain? Like if 0 is no pain and 3 is the worst pain, where do you think the pain is? How much is the pain? Did something happen which started the pain? Is the pain like a steady pain? It is coming and going pain? So you are going to ask what type of a pain the patient is having. Okay. Then when the patient says that, okay, this is the type of pain and all that. So depending upon what history patient gives, you can try and correlate. Maybe the patient's pain is more like a burning sort of pain, and she's having more in the epigastric region. It started after having some oily, spicy food. Then you will start thinking that, okay, maybe it is something to do with a gastritis kind of a pain. Yeah. Also, because she's pregnant, it is very important that you rule out that she's not going in any early labor. She's not having any vaginal bleeding. So you are going to be asking these type of things as well. Fine. So once you have taken, yeah.
Sorry, please. So regarding the pain, if I understand what you're saying, you have to ask where the pain is, right? Where she's having the pain. Okay.
Yeah.
All right.
Yeah, because see, any pain, you first need to understand that where is the pain, how did it start, what happened, was there any trigger, what kind of pain it is, because only then you will be able to understand that whether the pain has to do anything with her pregnancy, or it is a totally separate pain that she's having.
Okay.
And you are going to be dealing with it the same way. Then you are also going to take the history of her pregnancy as well, that okay, that what is her gestation, yeah, what is the parity of the patient, yeah, do you understand about the gestation parity and these as well? Do you know if I'm writing as G1P2 or sorry, G2P1, if I write that one, do you understand that what does that mean?
Yes, ma'am.
Okay, just explain it, Mercy.
Yes.
What does that mean?
The G stands for the gravity, which means the number of pregnancies she has had, the number of pregnancy, and the parity means the number of case or the miscarriages she has had.
Yes. So the gravity is that how many times she has been pregnant, regardless of whether they actually she delivered them or not. That is, and parity means that how many of the live babies that she has. Yeah. So if we say G2P1, that means that she has been pregnant twice, and she has got one live baby, and then the current one that she is pregnant with. Okay, so we need to figure that one out as well, that whether she is a she's the first time mother, or whether she has already had been pregnant before, because that sometime is going to tell you a little bit, then you will get a little bit more of the obstetric history that you are going to be taking from her. Okay. So you are going to, once you have taken the presenting complaint, you have taken a bit of obstetric history, then you are going to be doing the assessment on the patient. Now over here, in the assessment, there are going to be two things that you are going to be doing the assessment. The assessment of the mother and the assessment of the fetus as well that you will be doing. So in the assessment of the mother, you are going to be doing the full A to E assessment, where you are going to be checking the airway, breathing, circulation, disability, and the exposure of the mother, where you will be taking, yeah, as we had discussed earlier, you will be checking her airways, you will be checking her respiratory rate, oxygen saturation, pulse, blood pressure, CRT. You will be checking that she's alert and she's not confused by anything, and what her temperature is, because all those things you will have to chart on the meows chart. But apart from that, you are then going to also be checking for the fetal well-being. So for fetal well-being, you will need to check her abdomen. Now, when we are checking the abdomen, and Priscilla, you can tell me that how do you make out that how many weeks she might be pregnant? Say, for example, she has told you that she's 34 weeks pregnant. How do you assess or make sure that, yes, the pregnancy or the abdomen is also looking similar to what it would look at a 34 weeks pregnancy?
You can measure the symphysis fundal height with a tape measure
Yes.
to check.
Yes. Yeah, so that is one way of doing that. You can measure the symphysis fundal height, but also as the more experience you become, you will also be able to also see that how far the fundal height is, how much is the fundal height. And you should be able to check that, make an assessment that yes, it is around 34 weeks pregnancy that the lady is pregnant around that time. So the baby is looking, or the fetus is looking fine. So you are doing the abdominal palpation. When you do the abdominal palpation, what all are the things that you will be checking in total? Priscilla, tell me, what all other things? So apart from you have done the symphysis fundal height and it is corresponding to the gestation. What all are the other things that you will do?
You can check for the descent, the lie, the presentation. You can also check for the fetal back to check the fetal heart rate. Then you check for presentation. You can also inspect the abdomen for any gravidarum, linear regral, or scars or anything. And what else? I think that's all I can say for now.
That's good. So you have covered most of the thing. Now, what I always suggest is that, see, whenever we are going to do any kind of observation or assessment, or then the first thing that you should do is, first you are going to be, before you make any, even touch the patient, you should do the observation. Yeah. So in observation, you will be able to see that whether there is any scar, whether there is any kind of maybe she have got the first one might be a cesarean section or something. You will also be able to see what is the type of skin, what is there, and if there are any rash or any bruises, any of these type of thing. And you will also be able to see if there is any fetal movement as well at that time. Yeah. But you might not be able to see the fetal movement. Sometimes you are able to. Then once you have done all these things, then you are going to be touching the abdomen or doing the palpation. Now in the palpation, the first thing that you are going to be checking that whether the abdomen is soft or whether it is tense, because that is also going to tell you few things. If the abdomen is soft, that is what you will expect. If it is tense, then you will need to figure out that why it is tense, whether there is an active contraction which is going on, which is making it tense, whether it is a tense abdomen can also be if there has been any abruptio placenta, or whether there is any kind of the amniotic fluid is a lot more, and or if there is some other issues, medical issues which are going on, which have made the abdominal tense. So you need to figure that one out. After that, you are going to also check the things which you have told me, that what is the presentation. And presentation basically means that which part of the baby is pointing towards your symphysis pubis. Yeah, so normally it is going to be the cephalic presentation, which is like the head is down. But that usually happens around like 34, 36 weeks, towards the end of the pregnancy. The baby's head is the one which is down. Before that, when the baby is too small, it is possible that the presentation can be something different, like breech and all that. So we know the presentation. If you want, as you spoke about descent, we also want to see that how far is whether you are able to feel the presenting part above the symphysis pubis, or you cannot feel it. So if the patient is in labor, or when just before the delivery, you will not be able to feel the entire fetal head. So you will be able to feel only depending upon that how far it has gone, that whether it is engaged or whether it has gone below the symphysis pubis. So you'll be able to feel that one. When you mentioned about that to feel the back of the patient, so you want to know the lie or the back of the patient, that which side the patient is lying on, or the fetus is lying on, because then you will be able to hear the fetal heart sound as well. And you can use either a pinard or a Doppler to hear the fetal heart. Yeah, and while you are checking all these things, you can also feel the fetal movements as well. Yeah, so these are some of the things that you will be able to check when you are doing the assessment for the fetal well-being. Have you understood?
Yes.
Okay, anything I need to explain further in this one? No? Okay. So now,
Doctor, please, so
yeah.
during the examination, is the assessor going to tell you, maybe you verbalize that you are assessing for the fetal back? Is the assessor going to tell you maybe the back is left or right? Because
See,
it's a mannequin.
you will be getting a mannequin. In the mannequin, you will be able to feel is going to be a fetus inside. So you should be able to figure it
Okay.
out. Yeah.
Okay.
So
All right.
they can put the fetus inside the mannequin, and you can make some assessments that how what it is.
Okay.
Yeah, you will not be able to hear the heartbeat and all that, but you will be showing that how you will listen to the heartbeat using a pinard. In the exam, they will be giving you a pinard. You know how the pinard looks like?
Yes.
Yeah, it's a conical kind of a
Yeah.
thing which you will put on on the area where you feel that is the back of the baby, and you will be able to hear the heart sound from there. Okay, so now what we have done is, see, we have done our introductory 6. We have taken the history of the presenting complaint. We have done the observation, maternal observation using the A2E assessment. We have done the fetal observation by doing the abdominal palpations and going through the checking for the fetal well-being. We have done all these things.
Yeah.
Then we will also be checking for the urine analysis, and this normally
It seems we omitted something. We have to time for contractions, right? If you are assessing, if you are thinking about early labor, you have to time for contractions. So with contractions, I know we time for 10 minutes. So during the exams, are you going to time for 10 minutes?
No, you are not going to be doing that one. In the antenatal, first of all, we'll talk in both scenarios, in real life as well as in the exam. In the exam, it is very, you will not be getting a scenario where they are saying that the mother is in early labor. That is not going to be the scenario. Yeah. So, but in real life, you might have someone, and in that one you are going to be checking with the lady that whether they feel that the pain is coming and going, whether they are getting like a contraction like of a pain, whether their tummy gets hard or not. Okay, so if the female says that yes, I feel that I'm going through the contractions, then you can say that okay, we will be, while I have done this examination, during this time you have not got any contraction. Currently your abdominal is feeling quite soft and nice. So as soon as if you start getting what you think is a contraction, start feeling hard, I'll be over here to check, and then we are going to be timing it accordingly. Yeah, you can just say all these things. You don't have to actually sit over there and time the contraction.
Okay.
All right.
Okay, so then we come to the next thing is that we'll need to check for the urine analysis as well. And in this one, we are, if in the real life, of course, we are going to be wearing PPE and all those to check for to check the urine. But in the exam, you can ask, the examiner will already be providing you with the readings for that. They will say that if the urine analysis has been done, and they will give you the reading as well, that the urine has been checked and that there is no protein, no ketones, or they might say that okay, there is 1+ of protein and all that sort of thing. 1+ of protein is also not something significant that you don't have to mark it in the Meows chart. It is only after 2+ of protein that you are going to go ahead with that one. So you are going to be doing that one. And once you have done all these things, then you are going to be completing your Meows chart. So now I had shared the video in which I have shown you how to complete the Meows chart. So I hope that both of you have seen it, but we are going to go through this one very quickly again. We have understood that the Meows chart is basically the modified obstetric early warning scoring chart. Yeah. And in this one, you'll know that you are going to get an identification label. So please make sure that it is matching with your patient's record. And after that, you are going to put the date and time over here in this one column. You are going to plot your respiratory rate over here, the oxygen saturations. If the patient is on oxygen, then you are going to be putting that one. You are going to mark the temperature, the heartbeat, the systolic and diastolic blood pressure. You are going to write about the urine, if they have passed or not, and if they have passed, then whether there is any protein. As I said, that 2+ of protein and more are the one which is significant one, which you are going to be writing over here. Okay, you are also going to be checking about the amniotic fluid as well, that you will check with the patient that if they have noticed any discharge, what kind of discharge it is, whether it is a thick discharge or a watery discharge, what is the color of the discharge. So that is to check that whether actually the patient has ruptured the membranes, or if they have ruptured, then whether it is the amniotic fluid or it is just any discharge that they are getting. So you are going to be checking for that as well. If like if you feel that patient is in early labor or they have come with the early ruptured membranes, then you are going to be noting whether there is amniotic fluid and what is the color of the amniotic fluid, whether it is clear or pinkish or whether it is green color. Now, what does the green color signifies? If the amniotic fluid is greenish, meconium. Yeah, that means that what is happening to the fetus?
Distress.
So that means that there is urgent sort of action that needs to be taken, which usually is that the baby needs to be delivered urgently. So most likely there is going to be an LS cesarean section, which they will need to go through if there is already a meconium or the amniotic fluid is greenish in color. Yeah. Then you are also going to be checking the neuro response or the disability, where you will be checking whether the patient is alert. And if they are not alert, then whether they are responding to voice, whether they are responding to pain, or they are unresponsive. Okay, so again, just want to say that please do not get confused with this pain as the pain score. This is not the pain score. This is just to check that whether they are responding to voice, pain, or they are unresponsive. Okay. After that comes the pain score, where you can check with the patient that what is their pain and then score it accordingly. And an antenatal lochia is not relevant in antenatal. That is going to be for the postnatal one. Also, you are going to be checking whether the patient is looking unwell or not. And that you can check with your examiner. That examiner, is my patient looking unwell? And whatever the examiner says, accordingly, you can complete this one. So once you have completed this one, you will know that what is the total number of amber boxes and what is the total number of red boxes that you have had. Now, depending upon that, you are going to decide that what is going to be the monitoring frequency. So you can see that if there is one amber box, this is the advice that you are going to be giving, and your monitoring frequency becomes every 1 hour. If there is 2 or more amber boxes or one red box, then your monitoring frequency becomes 30 minutes, every 30 minutes. And if there are 2 red boxes, then your monitoring frequency becomes every 15 minutes. Yeah, and these are the advice that you are going to be giving. In the exam, you are going to get this part of the chart as well. So you will get this key as well along with this meows chart. So you don't have to mug up or don't get worried about that one. So depending upon what is the number of the chart, the color that you have got, you are going to be writing the monitoring frequency over here, that whether it is 1 hour, 30 minutes, or whether it is 15 minutes. And escalation of care, you are going to escalate the care definitely if it is the monitoring frequency, if it is in 30 minutes or if it is every 15 minutes, because obviously because of the abnormality. And then you are going to be putting your initials over here. That means that you are going to be signing the chart. This is how you are going to be completing your meows chart. Okay, any question on this one?
Yes, Doc. With the charting of the meows chart, especially with the blood pressure, I always get confused. When you are plotting, let me say you had a blood pressure of 140/90.
Yeah, so you are going to be 140 systolic. So you are going to be putting the arrow on this line because this dotted line is 140 over here, and 90 you are going to be putting over here in this amber sort of thing, and you are going to be joining both of them with a dotted line.
So you see,
this is where the systolic is.
140 is in the white box. By the 90 is being in the amber box.
Amber.
So when
so you are going to be, you will count it as one amber.
Okay. All right. Yeah, at times I get very confused about that. Okay.
Yeah. See, in the adult news chart, you only consider the systolic blood pressure. You only take account the systolic blood pressure. You are not looking into the diastolic that much. Yeah, so from the counting point of view, you are only counting the systolic one. But over here, you are going to be counting both systolic as well as the diastolic blood pressure. Because of the risk of eclampsia, preeclampsia, and all those things, you have to be more aware of this one. Okay.
So in case, let me say another one. So in case, let me say the blood pressure, the systolic fall within 150. So you are going to count to 150, 90. So you are going to count 2 amber boxes here, right?
2 amber boxes, yes.
Okay. All right. Okay. Thank you very much. Thank you.
No problems. Okay. Priscilla, any questions from your side?
No, please.
Okay. Okay, that's fine. So then we seen that what we are going to be doing with how we are going to be completing this one. So this actually completes our the assessment of the antenatal. Yeah. So what all are the things that you have done? So you have done your introductory 6. You have done the history of the presenting complaint, and then you have done in the history, the presenting complaint, the obstetric history, the past history, the medical history. You are going to be taking all those things, and history of medication, allergies, and all that sort of things. So history taking is there. Then you are going to do the observations. And in the observations, you are going to do the maternal observation and complete the meows chart. And you are also going to do the fetal well-being, where you will be palpating the abdomen. You are going to be checking the symphysis fundal height. You are going to be checking for the presentation, lie, and fetal movements. You are going to be checking the fetal heart rate as well. Yeah. And then you are going to be completing the meows chart, plotting all the things, and you will also be telling that what is your advice, and what are you going to be doing, what is your monitoring frequency on this one.
Okay.
Okay, so all of this is going to be completing your assessment of the antenatal patient. Now, whatever complaint the patient has come from, the sequence you are going to be using the same. Okay, so we discussed about the abdominal pain, but the patient can also come with a PV bleeding. So you are going to be asking about the PV bleedings. I say in the history of the presenting complaint, you are going to be checking about the bleeding, that for what kind of bleeding it is, how long has the bleeding been, did something trigger the bleeding, is it like a fresh blood or a brown sort of blood, along with the bleeding, is there any pain is also there, and whether the patient is having any other discharge. So all these kind of things you are going to be checking with the patient for the presenting complaint.
Okay.
Any questions in the assessment? Anything that you think that we have missed? Okay. Fine then. So as we go along, we will be discussing other things as well. So if there is anything that you feel that we have missed, then we can always cover up. So, but if I just quickly look at the criteria, let me just see the criteria as well. So, yeah, so I don't think that we have missed anything. So in this one, just one more thing is that to be aware of that, see, whenever you are going to do any kind of examination of the patient, even if it is an abdominal examination that you are going to be doing, or the urine analysis, I had already said that if you are going to be doing the urine analysis, then please don't forget to wear the PPE. You will require to do the urine analysis after wearing the gloves and apron. Yeah, because this is a body fluid that you are dealing with. And after you have done your abdominal observation, before and after, you are going to be making sure that you clean your hands again before you touch the patient and after you have touched the patient, because these are just things which we know that the places whenever we have to do the hand hygiene. Okay, so
with the assessment, when you are doing the assessment, please, do you have to put on PPEs or is not necessary?
Not just for history taking and not for taking pulse, temperature, blood pressure, not for these things. If you are at risk, yeah. Say again.
Right. I'm listening, please. Nothing, please. I'm listening.
Yeah, so until and unless you are at risk where you are going to be coming in contact with the body fluids, then of course you are going to be wearing your PPE. So like if you are doing a urine examination, if you are going to be doing a per-vaginal examination, then of course you are going to be wearing the PPE. But over here, we are not doing any of those things. If the examiners, if they say that, okay, the urine sample is kept over there and you have to check, it is possible that there is a dipstick is also kept over there for you to check that whether there is any protein in that urine or not. Then you are going to be wearing your gloves and apron and then check whether there is any protein in the urine. But it is also quite likely that the examiner will tell you that we have already done a urine analysis and there are no proteins or 2+ of protein or whatever. They can just give you a finding of that one, in which case you are not going to be doing that. But it is not, you can always say that it's, since I already have my protein, my urine analysis reading, I'm not going to be doing that. But if I had to do it, I would make sure that I wear a PPE before I do my urine analysis. It is just a thing that you have to tell the examiner that you are aware of when to wear a PPE.
All right.
Okay.
Okay. So that covers your assessment for the antenatal. Now, hopefully the rest are going to be quick ones because we already have done quite a few things over here. So now we come to the next one, that you can get a patient who is already in labor and is going to deliver. Yeah. So now the history is going to be slightly different over here. Although the approach is going to still be the same, that you are going to just do the introductory 6 again, and you are going to say that, okay, I have gone through your history and I can see that you have been having contractions or that you have already ruptured you are full term and you have ruptured the membranes and you are in labor. So I'm here, I'm going to be monitoring your observations and things and the progress of labor throughout. Is it okay for me to just go ahead and do some observations now? So you will tell the patient that your purpose and you are going to gain consent. Okay, and then you are going to be you are already given the detailed history, but you are going to be taking the history again just to reconfirm. Because in the reality, you are going to be writing the history at that time. In the exam, of course, you will be given the history as well, but you are going to still be reconfirming everything. So you will take the history of the presenting complaint, that if now over here, it is not really complaint, but the complaint is that the patient is in labor. So you will be asking about that, okay, since when has she been having contraction? What is the type of contraction that she's getting? For how long do they last? What is the interval between each contractions? And you are also going to ask about, has there been any discharge? Has she ruptured the membranes? And has she had any bleeding or anything like that? So and generally, how has she been feeling in herself? Has she passed any urine and all those things? So you are going to be asking all these things. And of course, the obstetric history, the gestation, parietal, pain, ruptured membrane, these ones I have already said, you are going to be doing that one. You are also going to be taking the observations, but over here, the observations, although I would still ask you to make sure that you are still taking the observation based on A to E assessment, But in the partogram, there is not many things that you will need to fill. Partogram is more towards the progress of labor rather than it being more like a meows kind of thing. But you will need to take the pulse, your blood pressure, temperature. You can always say that, okay, just going through the A to E, that I can see that you're talking to me, so your airway is fine. I can see your breathing is also okay. Sometimes it is possible that she's breathing a little bit fast because of the pain that she's having, because she's active labor. And you can check the pulse. Pulse can also be a little bit high because of the pain and the active labor. You check the blood pressure and you check the temperature and urine as well. You will be given the urine analysis as well for proteins or ketones. Same sort of thing over here. And then you are going to do the abdominal examination. Same sort of abdominal examination that you are going to be doing, that whether you are going to check the abdomen, you are going to be making sure that it is soft, or whether there is any contraction which is going on. Then the fetal movements, you are going to be checking for heart rate, the fetal lie, presenting part, engagement. Over here, you are going to be checking for the engagement as well. Now, when we say engagement, how do you think that the engagement is? Like, how do you explain engagement? Just tell me. Priscilla, tell me that how are you going to figure out that what is the engagement, and how do you know that how much is the engagement? What is the engagement?
If whether the head of the fetus has descended into the maternal pelvis, or
Yeah, see, when we say engagement, basically it is, what it means is that now the presenting part is fixed. Yeah, it is now. See, when you are, if the head is not engaged or the presenting part is not engaged, you are able to feel it and you are able to move it. Yeah, because till now it is not fixed. But the engagement means that it gets fixed, that now that is the part it is going to come down. It is not going to move. Yeah, and the engagement depends upon it is almost like in fifths, you are going to say that, okay, it is the 3/5 of the head, is because you will be able to feel the presenting part a little bit above the symphysis pubis. Yeah, if it is totally gone below, then you are not going to be able to feel anything, which means that the head is totally down. It is probably by that time, the crowning is already happening if it is totally gone down. Okay, so when you are describing that the head is, and if I'm talking about head because cephalic is the most common presentation, that the head is, you can say like 3/5 of it is engaged, or 4/5 is engaged, or 1/5 is engaged, depending upon how much you are able to feel it above the symphysis pubis. Okay, so you are going to be talking about the engagement. You are going to be talking about the contraction and the frequency of the contraction as well. And apart from that, you are going to be completing the partogram as well. Now, we are going to have a look at the partogram, that what all are the things that you will be completing in the partogram. So this is how the partogram is going to look like. Can you see it?
Yes, please.
Okay. So over here, you will need to put your name, then the name of the patient, gravida, para, hospital number, their blood group is going to be there, the date of admission, time of admission. If the membranes have ruptured, then that whether they are ruptured or not ruptured, and if ruptured, then how long ago was that? How much time has it been since the membrane ruptured? Yeah, so all these things you will have to fill over here. Then because the partogram is the record of the patient being in labor, it is going to be in the hours, like the first hour, second hour, that how many hours has it been since you started the partogram. So this is already written, the 1, 2, 3, 4 hours. You are going to put the time when you are first going to be filling the partogram. So that is when the hours are going to be starting. And then you are going to be, the first thing that you are going to be completing over here is the fetal heart rate. So you will write whatever the fetal heart rate is over here. Then you are going to be checking for the amniotic fluid. that whether the amniotic fluid is present or not present. Then you are going to be also checking for molding. Now, when we say about molding, what do you understand by molding? Any one of you can tell me, Priscilla or Mercy. What do you understand by molding?
When the bones of the head, how they overlap when the baby is coming out or when it's being delivered.
Yeah, so it is, I know you know it, but you are finding it hard to describe it. So see, when the baby is like it is the fetus, at that time, the bones, the skull bones, they are not fused, so that there is a very thin membranes between each joint. Yeah, now that allows, if the head is this big, what that allows is that because there is a soft part in between, the bones, they overlap each other so that they reduce slightly the circumference of the head, and it's make it easy for the baby to be born. That is what is called as the molding. So when you are going to be doing a PV examination, you will be able to feel that whether the molding is there, because the bones are going to be one on top of the other. So they are overlapping kind of thing. So you will not be able to feel the soft membrane. Yeah. So that part is called as the molding. So you are going to be checking if the molding is happened or not happened. Then there is also the cervix. So see, these findings will be given to you. You are not going to be doing an active PV examination. They are going to give you the findings of this one. Yeah, because it's a mannequin that is going to be there and you will not be able to do, but you need to understand all of these things, that when you do a PV examination, that what are the things that you are going to be finding. Yeah. So the cervix, we know that the full dilatation is still 10 centimeters is the full dilatation.
Yeah.
And how do you figure it out, the full dilatation? Or the dilatation, how do you check it?
By
Your
using centimeters,
fingers.
your fingers.
So, yeah, so when we do the PV examination, it is the 2 fingers that you are going to be examining with. And the first thing that you are going to be checking is going to be when you reach the cervix. Now, when you reach the cervix, what all are the things that you can check? The first thing that you are going to be checking.
First,
Try and imagine.
I think first, with the cervix, you check the consistency of the cervix.
What do you mean by that?
With the consistency of the cervix, you check because you are checking whether the cervix is thin or is soft.
Okay. First thing that what we are going to be checking. See, imagine that this is the cervix. Can you see my fist?
Yes,
Yeah.
please.
Imagine this is the cervix. So this is the internal, your external os. External os is so the cervix normally has 2 openings, the external os and the internal os. Yeah, so you are going to see the external os. So these 2 fingers are coming. So the first thing that you are going to be coming across is the external os. Over here, you are going to be seeing that whether it is closed or whether it is dilated. Yeah. So you are going, if it is dilated, you are going to check that how much it is dilated, whether it is 2 centimeters. So because you are going to be opening your fingers between the cervical os. And you will see that whether it is 2 fingers or whether it is 2 centimeters, depending upon how big it is open, how big it is dilated. So you are going to be checking in this way that, okay, how much is the dilatation. But what you need to also check is the thickness of the cervix. And the thickness is that as your cervix is going to dilate, it will become thinner and thinner and thinner, almost as much that your internal os and your external os are almost mixed with each other. Okay? That thinning of your cervix is called as the effacement. So like it is almost as if the cervix, as it is dilating, it will keep on getting thinner and thinner and thinner because it is dilating. Okay, sometime what happens is that the effacement, now if it is a primipara, if it is the first time pregnancy, then the effacement is going to happen first and dilatation happens later on. In the multipara, they can happen almost together. So when it is possible that you are going to say that actually the dilatation is only about 2 centimeters, but the cervix is fully effaced. That means that the cervix is fully thinned. So if the cervix is fully effaced, then the dilatation is going to happen quite quickly because it is already effaced. Now it is only the fact that it has to get dilated. So effacement also happens as the head is going to, or the presenting part, when it pressurizes the cervix, that is when the cervix starts getting thinner and effacing, which means that obviously the head is like pressurizing. So the head is already over there. Now the cervix just needs to dilate and the delivery is going to happen. Okay. Have you understood that one? That what is the, how to figure out the cervix and the effacement?
Yeah.
Okay. So now that we know what is the cervix, we also know what is the effacement. Now we need to figure out that what is the presenting part, what is the ratio, where is the presenting part, how low down the, and that is called as the station. That what is the station of the presenting part. Now, how do you figure out the station? See the next one, the descent of the presenting part in relation to the ischial spine. So that basically is the station. So you know that when you are, you know the ischial spine. So when you go into the cervix, and if you are going to be checking in the vaginal sort of area, you will see the 2 bony prominences. You will feel that that is called the ischial your ischial spines, and that is called as a zero station. Okay, so if your presenting part is above them, it will go on the negative sort of thing, that it is -1, -2, -3, depending upon how high it is. But if it is coming down those bony prominences, then it will come as a +1 or +2 station. Now, when it is coming down, it is almost imminent that now the delivery is going to happen because it has crossed the ischial spines. Okay, so it is important that you are going to find the station. So now imagine again that when we are going to be doing when we want to check or make the assessment of how far the lady is in the labor, you are going to do the abdominal palpation, in which you are going to be finding out the presenting part and the engagement from over there. And for the PV examination, you are going to find out that what is the cervix, the dilatation of the cervix, the effacement of the cervix, and presence of the amniotic membrane, because you will feel the amniotic membrane as there, and you will also feel the bulge of the amniotic membrane, and you will also be able to say that whether they are ruptured or not ruptured, and you are going to be able to feel the station, that what is the station. Okay. Got it?
Yes.
Yeah. Okay, so, and you are also going to see what are the contractions. That contraction per 10 minutes, that how many contraction is she getting in every 10 minutes? In 10 minutes, how many contraction are there? 1, 2, 3, 4, 5, whichever. Have you understood this?
Yes.
Okay, then we'll look at the next page. Okay, so it will continue. And then the next, then you will also need to know that what all are the drugs that you have given. See over here, the hour and time, you will have to write the time again over here. Yeah, that by what time you have already, so till up to the PV examination and thing you are going to be doing over there. And then you will write the time again over here. And then you will need to also write that whether there have been any medications or IV fluids that have been given. So what can be the medications which we might be giving to the patient?
Infusion.
Yeah, so we might give the infusion. That maybe if say the female was in non-progress of labor or something, then they might have started an infusion. It is also possible that she was given Entonox or a painkiller or something of those kind of things might have been given, or maybe epidural was given. All those kind of things, whatever was given, you are going to be recording it over here. And then comes the part where a little bit of a maternal sort of observations are there. So you are going to be writing the pulse and the blood pressure and the temperature over here and the urine analysis. Yeah? And in the end, which is very important, your signature. Now that completes your partogram. Is there anything that you want me to explain again in the partogram? Anything that you have not understood? Anyway, as I said, that I'm going to be doing a separate video for the partogram and I'll share it with you. But I think that we have pretty much gone through whatever is going to be required. Mercy, Priscilla, anything that you?
It's about the time. You know, the initial time.
Mm-hmm.
Is it the same thing you write under the second one, or there will be different times?
Now you write the time over here. See, in reality, there will be different times because by the time you do all these assessments and everything, the PV examination, the fetal heart, amniotic fluid, all these things that you are going to do, yeah. And then when you reach the time when it is, you have to write about the drugs given, pulse, blood pressure, all these things that you are going to be doing. The time would have changed. But in your examination, yeah, they would give you the time as well, that okay, these are the times and you can put that time over here.
Oh, okay.
Okay.
All right,
Okay.
Doc. So I want to talk about the plotting of the partogram.
Yeah.
Please, can you go back a bit because we are the last page of the partogram. Can we? Okay. So let me go this side. I hope with the fetal heart rate, we are using dots as we use back home,
Dots.
right?
Yeah. You'll be using dots
on the line.
In not on the line, in the box.
So you use the let me say you had 140 beats per minute. Are you going to plot it here? Because back home, before you plot
Actually, you will plot it on the line, because I'm just sort of looking at this one, because in everything else you usually put in the box, but over here they have given this total as one box. So and the line is in the middle, so you'll plot it on the line then.
Okay.
Yeah.
And with the molding, I wanted to know, are we just writing, if there is molding, are we writing molding?
M.
If there is no
you
molding, you write none, or we are using the one in the books, like if it's +1, you write plus. If it's overlapping, you write 1. If it's overlapping and it can be separated, you write +2. If it's overlapping and cannot be separated, you write +33, or you are just using these symbols. If there is molding, you write molding or none.
Yeah, so yes, I think that over here they have just said whether it is molding or it is not molding. They have not asked that if there is molding, then how much is the molding. They have not given any of that rating. So I would say that either you put a molding or then none. Yeah, so just either M or N. So you write those ones. So for M is for molding and N is for none.
Okay. So there again, let's go to the temperature, please. The maternal observation. All right. So with the temperature and with the observations, I can see we are using an arrow. What has been indicated there? So
this arrow,
with this,
so it is not for the
yeah.
temperature. This
No,
arrow is for
blood
the
pressure.
blood pressure. So see over here, you are plotting in the same these things. You are plotting the pulse as well as the blood pressure. So the pulse you are going to be by a dot, and the BP you are going to be doing by the arrow. So say for example, your blood pressure is 140 by 80. So you are going to put the arrow from here to here. You are going to be making the arrow this way, like that.
Is it on the line or in the box?
See, for the line and the box, I will clarify it with you. I think that normally it is going to be in the box, but over here I can see because they have given the entire box otherwise, so it is possible that it is on the line. But let me just come back on you for this one, that where are they plotting on this one? That whether they are taking two readings over here or whether it is the middle one. I'll come back to it. But it does not matter whether you are going to be doing it on line or whether you are going to be doing on side. That anyway, I will tell you. But for the arrow and the dot, it is going to be that you are going to be marking the arrow, the full arrow over here for the blood pressure. And if your pulse is 90, then on the same arrow, you are going to be making a dot over here to say that that is the pulse.
All right. Okay. Thank you.
Okay.
I'll be waiting for my feedback.
No, when I will do a video of this one, by that time I would have already clarified, and I'll show you that how it is exactly done.
All right.
Yeah.
Thank you very much.
Okay. Fine then. So that completes our the assessment for the patient who is in labor. Okay. So any questions on the labor one? Assessment for the labor? Okay, good. So now we are coming to the assessment of the postnatal. Yeah, so when we do the assessment of the postnatal, again, the same sort of thing. Now over here, obviously the lady has delivered. So you are still going to do the introductory 6. And after doing the introductory 6, you are going to be taking the brief history the same way, like what is the history, their medical history, antenatal history, intrapartum history. So, and the very recent history, that currently how is she feeling. So you are going to be taking all that history. You are going to be doing the full A to E assessment. But apart from the A to E assessment, there are few other things also you are going to be checking or asking the patient. So now, because after birth, it becomes important for you to take the history, like the breast and perineum discomfort history. So because now she would be breastfeeding, that whether she has already started breastfeeding, whether if yes, then whether she's getting enough milk, colostrum, she's not having any like breast engorgement or hardness or pain in the breast, the nipples are soft and supple, there is no cracking nipples and all those things. So you have to take the history of these things. And you are also going to be taking the history of the perineum, that whether she is having any pain, whether there is any history of, if she had some episiotomy or tear or something, then you will need to check for that one. Yeah. And you will also be taking the mental health and well-being history, because we know that there can be postnatal depression, and because it's a very emotional sort of thing that you go through. So it is important that you are going to be taking some history of mental health and well-being. You will also be taking some history of that, whether she is socially being supported by by the family, that there is someone looking after her, whether she's getting enough sleep, whether she's well rested. So all those things that you will need to check. And also you will need to take the history of the lochia as well, that what kind of discharge she's getting, whether it is a normal discharge or it is more than normal, whether she's getting a lot of bleeding after that, whether there is the discharge is smelly discharge. So you have to take the history of all these things in order to make sure that you do a full postnatal assessment. Fine. And then after you have taken all these history, then you are going to be obviously filling out the meows chart as well. And you will, according to the meows chart, you are going to be saying what should be the observations, depending upon what you have plotted over there. And you will be giving the patient some advice, education as well, with regards to the healthy diet, fluid intake, rest, breastfeeding, and postnatal exercise, pelvic floor exercise, all those kind of things. You are going to give some education to her as well, along with, so when you are explaining the meows chart, that okay, this is what your meows reading is, this is how we are going to be observing you, this frequency. But apart from that, we will also like to make sure that you are taking care of having a healthy diet, you are having good fluid intake, and taking adequate rest. Breastfeeding, you can check that if she's okay with breastfeeding, then that's fine. Otherwise, you can ask the breastfeeding nurse to also come and show her that how to do if she's struggling or if she's having any problem in doing that. You can also tell about the postnatal pelvic floor exercises and how to take care of the perineum as well. So you can try and tell that as well. You can even say this thing that I'm going to be sharing a pamphlet or a leaflet with you, which details all the pelvic floor exercises. So you can go through it and you can just make sure that you are doing those exercises to make sure that you are not having any problems over there. And if there is obviously any abnormal finding, like say, for example, if the lochia, you feel that they say that it is smelling or like that, and then you can say that, okay, I will have to do an examination. And as part of the examination, you can also take a swab just to make sure that she's not having any infection over there. You will not need to take the swab, but you can say that you are going to be examining and that you are going to be taking a swab as well, just to make sure that there is no, the discharge is not like an infection that she's having. And sometimes it is also possible that if she has got stitches because of the episiotomy, then it is possible that the discharge is coming from there. Maybe the stitches are the one which she has got infection over there. So you might have to check that one.
Okay.
Okay, so any now that we have completed all three of the assessment, any question in any of the assessment?
The timing, how you are going to manage your time to meet all these targets?
You will. In fact, I would say that you will be left with time. So generally, you will be able to finish all of this thing within 14 to 15 minutes.
Okay.
Yeah, and you will get 20 minutes to do that.
Okay.
So that is where you are going to be practicing. See, when we are talking, when I'm explaining it to you, of course we are using more time because we are explaining all the things. Yeah, over there you are not teaching anyone. You are yourself, you are just performing all these things. And that's why it is not going to take that much longer or that much time. Okay, but that brings me very nicely to what all are the things that you need to, the tips and things what you need to be aware of, or the common mistakes that people can make. Yeah, so common mistake in any of the things, not just the assessment, but in any of the things. See, communication is such a thing that we need to make sure that we are communicating it really well. Now, please remember, in the exam, what is inside your head, the examiner cannot know what is there inside your head. So that is why it is very, very important that you verbalize everything that you are saying. In real life, you won't have to verbalize as much because you are not under exam pressure. Over here, because it is your exam, whatever you are doing or not doing, please make sure that you verbalize those things. Okay? And your communication should be very clear. Please also read and understand what is your scenario and what instructions have been given to you. Because sometimes, because we are in so much of a rush that we want to finish it on time, you might not read the entire scenario and not pay attention to what is required out of you. So it is important that you do that. Time management, of course, you have already asked me that one. one of the things which I would always advise everyone is that please make sure as soon as you enter your station, check where the timer is. Yeah, and make a note that you are always keeping an eye on the timer, that how much time is left. In that way, you can pace your station. If you feel that you are going too fast, you can slow down a little bit. If you feel that you are too slow, then you can at least do things a little bit more quicker once you are aware of how much time is left. Of course, the other mistake people make are not checking for patient ID or allergies, or not taking consent from the patient, or not caring for the patient's safety or hand hygiene and all those things. And again, very, very common mistake people make is that they do not fill or the documentation are either incorrect or incomplete. So very important that you get used to making sure that you are filling your documents correctly. Okay.
Okay.
Doctor,
And
please,
yeah.
Again with the time, are they
Mhm.
going to prompt you? Are they going to prompt you about your time?
So normally they will tell you when you are about 5 minutes are left. Normally they will tell you that you have got 5 more minutes. Yeah, but if they think that you are doing all right and you are anyway looking, you are aware of the times, then they might not. But usually they will give you a warning at 5 minutes.
Okay.
Yeah, then the top tips. I think again we all know the top tips. Just stay calm. Easier said than done, but still try to stay as calm as possible. Understand the scenario and plan it. Involve the patient in the assessment. So the communication should be that the patient is also involved in your communication. Gain consent where PPE, wherever it is required. If you make any mistake, then please verbalize what, and if you realize that you have made a mistake, verbalize your mistake and verbalize and that how you are going to be correcting it as well. And as long as it is within your time, usually the examiner, they will take note of it. Yeah, and they will not penalize you for that one. Also, before you finish your meows or the partogram, please recheck it so that to make sure that you have not missed anything and that there is that you have completed it correctly.
Okay.
Okay. And that is all about it. So be as happy as these people are. Yeah, so that completes our assessment sort of station over here. So we have gone through the assessment of the antenatal, the labor, as well as the postnatal one. And we have also learned how to complete the meows and the partogram over here.